Dr. Kristen Keefe is a professor of pharmacology and toxicology at the University of Utah. Dr. Keefe holds a PhD in behavioral neuroscience from the University of Pittsburgh. Her research areas include neurological and neuropsychiatric disorders, including drug abuse and addiction. Her laboratory is interested in the functional neuroanatomy of the basal ganglia that plays a role in diseases such as Parkinson's disease, Huntington's disease, schizophrenia, and drug addiction. In her long career, Dr. Keefe has received numerous teaching and research awards and has also received grant support for her research work. Welcome, Dr. Keefe.
Thank you very much for having me. It's a pleasure to be here.
We're so happy to have you here. So, can you tell me why is studying the long-term consequences of methamphetamine-induced dopamine neurotoxicity important? Not just because it's a mouthful.
So from my perspective, I think it's important because I strongly believe we have to understand those long-term consequences to inform our development of therapeutic approaches to treat substance use disorder in general and methamphetamine abuse disorder in particular. And based on our research and what we've seen, it seems to me that we have an individual whose brain is fundamentally changed, not only from the standpoint of the plasticity that underlies the development of the addiction in the first place, but also the fact that methamphetamine, like other substituted amphetamines, are toxic to the dopamine and serotonin systems in the brain, and that loss and that impact on monoamine signaling in general and dopamine signaling in particular changes then the capability, in my view, of the brain to make the plastic changes that we might need for people to make long-term behavioral changes to address their substance use disorder. So I think if we don't understand how that toxicity impacts these systems, how our brain normally develops behaviors, makes behavioral change, then we won't be as successful as we might be in developing therapies and implementing therapies to help people overcome their addiction.
That makes perfect sense. I have a follow-up question that is
Mhm.
totally optional.
Okay.
Is there something about methamphetamine in particular that has a unique type of neurotoxicity that needs to be further studied?
So methamphetamine, as I just said, is one of a series of substituted amphetamines that we know can produce, excuse me, toxicity to dopamine and serotonin systems. The
Hmm.
different substituted amphetamines have relatively different selectivities. So, for example, MDMA or ecstasy seems to target the serotonin system more. D-amphetamine seems to more selectively target the dopamine system. Methamphetamine seems to more kind of affect both dopamine and serotonin systems.
Hmm.
Why the substituted amphetamines versus cocaine, for example, are toxic is an interesting question, and obviously still a subject of research to try to understand what it is about their mechanism of action that allows them to be toxic to these systems. Certainly, the dopamine and serotonin systems are highly vulnerable to toxic insults, perhaps because those molecules themselves can undergo oxidative changes and produce reactive oxygen species and so on in their metabolism. And so they're more vulnerable. I always find it interesting that the vesicular monoamine transporter, which is what packages those transmitters into synaptic vesicles, is actually a member of what's called the toxin extruding antiporter family, which might suggest that it evolutionarily developed to protect our cells from toxins. And it's kind of been used as a way of packaging those molecules into synaptic vesicles for neurotransmission, but maybe also in a very important function is keeping those molecules inside vesicles so they don't produce toxicity. And we know that the amphetamines really disrupt that storage.
Wow, that's really interesting. So I would imagine that picking the exact right model is important. So, what kinds of rodent models have been used to study these consequences, and how do you go about choosing a model?
Yeah, that's a very important question and a very good question. So, I think one of the fundamental questions we always have to ask ourselves is what is it specifically we're trying to model? And when we think about methamphetamine induced neurotoxicity in humans, obviously somebody has a methamphetamine addiction, they have a substance use disorder, which presumably results in the fact that they abuse enough of the drug to suffer the neurotoxic consequences. And so, and obviously, when humans administer or take these drugs, they're self administering. So, on the one hand, you have the option of using what's called a contingent model of methamphetamine administration, meaning it's contingent on the animal making a response. So the obvious type is a methamphetamine self-administration model where animals are in an operant chamber, they get IV drug infusions contingent on their responding in the operant chamber on a lever press or nose poke or what have you. Um, and many people feel that that's the best model system to use because it more closely at a kind of face validity level models the human situation where individuals self-administer the drug. So it's contingent on that. And there are some studies in the literature that suggest that for certain impact of drugs on neurochemistry in the brain, that contingency is important. Um, However, in my view, if you want to model methamphetamine-induced neurotoxicity, in my opinion, the self-administration model is actually not the best model. So there have been a handful of studies that have tried to look at the neurotoxic consequences of methamphetamine in a self-administration model. And those studies have variably reported different effects. So while there's generally a decrease in the dopamine transporter, which is one of the most reliable effects seen in human abusers of methamphetamine, a very large effect size. There was a meta-analysis published in 2017 showing in humans a large effect size in terms of decrease in dopamine transporter in individuals with a history of methamphetamine use. So that is reported in the contingent rodent models. Typically, these have been done in rats. But the extent to which that decreases there and the persistence of that effect is variable across these studies of animals using self-administration models. And there's nothing in the difference, there's nothing about the dose of methamphetamine used or how long the animal self-administered or during the day as well as across days that really readily explains the differences in outcome. And some of the other observations that have been reported in humans, such as glial reactivity, decreases in the serotonin transporter, and so on, have not been seen in those contingent self-administration models. So on the other hand, we have what are called non-contingent models of methamphetamine exposure, and that's where the investigator is administering the drug, or you have an animal in an operant chamber whose the administration of methamphetamine is yoked to the responding of an animal in a different chamber. So they get the same amount of methamphetamine, but that animal is not doing anything to give itself methamphetamine. It just gets an infusion when another animal gets an infusion. So in that case, so you have two different types of non-contingent models. Then you have a yoked methamphetamine animal in a self-administration study, or you have just investigator administered drug. And there actually is a study that compared the neurochemical effects of those doses of methamphetamine in the self-administering versus the yoked animal. And in that study reported no effect of contingency on the ultimate neurochemical outcomes. So that would provide additional information that the contingency, when we're thinking about choosing a model to model methamphetamine neurotoxicity, the contingency of the drug administration does not seem to be important in determining that toxicity. So in that case, then in my view, and the model we use in our laboratory is to use non-contingent administration where the investigator is administering the drug to the animal. And I think there are benefits there. It's much less labor intensive than having animals with jugular vein catheters, acquiring self-administering over weeks. And the model system, the non-contingent model that's typically used is what's called a binge regimen of methamphetamine administration, where we'll give 4 high doses of methamphetamine within a single day at 2 or 3 hour intervals. It's kind of varied a little bit. It's been used for decades. It was originally um, developed by Lou Seiden and Jim Gibb, among others, literally 35 years ago to 40 years ago. And in those cases, then you can acutely treat the animal with the drug, this binge regimen on a single day, and then allow the animal to recover from that treatment. And so what we end up doing is actually looking at the long-term consequences well separated from the actual day of exposure. So you remove any kind of acute pharmacological effects of the drugs, and then we can really just ask, what are the consequences of this toxicity on the functioning of the organism? And that's really the question that we've been most interested in, is what's the consequence of this dopamine loss on neural function? And so we've chosen this non-contingent binge regimen as a way of modeling that long-term toxicity. And
All
so
right.
to get back to your original question about why is this important, so there are two epidemiological studies, one out of Steve Kish's group at the University of Toronto, and then another one with Glenn Hansen here at the University of Utah. And both those two epidemiological studies have shown that individuals with a history of hospitalization for methamphetamine use disorder are 2 to 3 times more likely to develop Parkinsonism as they age. And so that suggests, at least for a subpopulation of individuals with a history of methamphetamine use, they may have this kind of protracted period of partial dopamine loss or progressive dopamine loss. And again, we're trying to treat individuals and to use behavioral therapies, if you will, to help these individuals manage their addictions. But the evidence would suggest, again, at least a subportion of them have this partial dopamine loss from their methamphetamine exposure. And so we really want to understand what's the consequence of that loss and how might we manage that better to help them benefit from therapies.
All right. You said that they develop Parkinson. Do they actually develop Parkinson's, or do they develop Parkinson-like symptoms?
Well, yeah. So Parkinson's disease as an entity, as an idiopathic disorder, we don't know what causes it.
Okay,
So if
gotcha.
we see Parkinson's symptoms as a consequence of a toxin exposure, then we just call it Parkinsonism.
All right.
Right.
What types of deficits have been observed in models of meth-induced dopamine damage?
So in humans, there are a number of deficits, although there's some debate still in the field as to how significant these cognitive deficits are. So there are deficits in verbal fluency, language, verbal memory, motor abilities, executive processes, prefrontal cortical. So all kind of implicating corticostriatal basal ganglia circuitry in terms of regulation of behavioral control and so on. One of the things that's difficult then is, as you think even about the model, is then what do we test in animal models? And so we and others have really focused on looking at behavioral tasks that target corticostriatal and prefrontal cortical functions to see if they're impaired. So again, separated from the acute exposure to methamphetamine, long term after that exposure, 3 months out, what have you, do those animals show deficits in these tasks? And so, for example, Chip Voorhees' group and Michael Williams at the University of Cincinnati have used what's called an egocentric response task on what they call, it's their maze. It's called the Cincinnati Water Maze. And that is a task that heavily relies on the animal's understanding of where they are in space and remembering sequences of movements in relation to their own body, which is it uses basal ganglia circuitry. And animals with methamphetamine-induced toxicity are impaired on that task. We've used a sequential motor learning task. So basal ganglia are heavily involved in learning motor sequences and patterns of behavior, and animals are impaired on that task. Interestingly, we have other data that on tasks that we know rely on basal ganglia function, the animals look at gross level, they look completely normal. But if you use approaches to interrogate what neural circuits they're using to solve that task, there's actually a shift. So while they look okay behaviorally, they're relying on different neural substrates to solve that task, presumably because of the damage to basal ganglia circuitry from the methamphetamine toxicity. And so this ties into this question of, well, if, and the kind of debate in the field, if you just do tests on individuals with a history of methamphetamine abuse and they seem relatively normal or slightly less than the control group, but still within the normal range on that particular task, you could, on the one hand, conclude that there are no impairments. On the other hand, if we're not like doing fMRI or something to look at what neural circuitry are they using to solve that task, we may be missing the fact that there's neural compensation going on for the damage. And while that might allow them to perform adequately when they're given a single task to do, when you think about our ability to flexibly modulate behavior and meet multiple task demands, if you're limited in the neural substrates you can use to solve tasks, then that's when impairments may become more apparent. So I think we have to be really careful in both the animal models and in the human studies to assume things are okay because on the behavioral task, the individual looks okay. I think if we know that we should be targeting tasks that we know depend on that circuitry and then doing something to make sure that that circuitry is still functioning optimally in the context of that task, not just whether the task can be completed within a normal range, if you will.
Yeah, that's a really important distinction. So now we get to the most important question. Do the deficits observed suggest potential therapeutic approaches to treating meth use disorder in humans?
So one of the deficits that my laboratories discovered in collaboration with Paul Garris at Illinois State University, who's a neurochemist, an electrochemist, is that the partial loss of dopamine induced by methamphetamine, so it's maybe a 30 to 50% loss of the dopamine innervation, selectively impairs what's called phasic dopamine signaling. So dopamine neurons can fire tonically, which is kind of a low frequency asynchronous firing, or they can fire phasically, which is a very uh, um, coordinated increase in the firing of many of the dopamine neurons. And so they fire at high frequency for a very short period of time. And that phasic signal we know is sufficient to support reward-based learning and very important for driving the learning functions of basal ganglia circuitry. It's not that the tonic isn't important, but the phasic plays this particular role. So we see this impairment in phasic dopamine signaling, and that led us to propose that if we could do something pharmacologically to restore the amplitude of that phasic signal, then perhaps that would restore the activation of plasticity cascades that are necessary to support learning. So we also know that the activation of plasticity related genes, such as activity regulated cytoskeletal associated protein or ARC, which plays a role in consolidation of long term memories. The expression of that is impaired in the basal ganglia of these methamphetamine pretreated animals. Long-term potentiation, which is a form of synaptic plasticity thought to underlie learning and memory, is impaired in these animals. So we think if we can restore the amplitude of that phasic dopamine signal, that we could restore these plastic processes, and that would allow an individual to benefit then from behavioral therapies that are trying to establish, for example, new behaviors in response in contingency management treatment approaches, let's say. So, or to extinguish their drug seeking behavior. So we know that the amplitude of that phasic signal is heavily driven by the release processes of dopamine neurons. And there's evidence in the literature that L-DOPA, for example, from Dave Sulzer's group at Columbia, had shown a number of years ago that if you give L-DOPA, so you precursor load, you can actually increase the amount of dopamine in the synaptic vesicles so that when the neuron fires phasically, it releases more dopamine. And so that would be a way of restoring the amplitude of that phasic signal. And we have preliminary data in the rats that it brings it back up to the normal level. The other drug that we're interested in and has already been tried repeatedly in clinical trials in methamphetamine abusers or individuals with a history of methamphetamine abuse, is bupropion, or Wellbutrin. So it's a smoking cessation aid, helps people stop smoking. It's an antidepressant medication. There's preclinical data suggesting that bupropion also would increase the vesicular content of dopamine and might also support increased phasic dopamine signaling. And so we are very interested in the possibility that acutely giving bupropion could restore the amplitude of that phasic signal, so that if you really kind of thoughtfully coupled, let's say in an inpatient treatment setting, you coupled the treatment of the individual with a dose of bupropion to support phasic signaling, and then engaged in behavioral therapy contingency management at that point, that you might allow the system to kind of hardwire that new behavior, those new behaviors that you want more effectively, because you would be restoring these critical mediators of brain plasticity at the point the individual is engaging in the behavioral therapy. And that might allow the behavioral therapy to be more, the outcome to be more persistent and to carry forward. So those are the kind of ideas where we think coupling, and other people, Steve Kish, for example, have speculated about the use of L-DOPA in the treatment of individuals with methamphetamine use disorder, because there does seem to be this population that has lower levels of dopamine, and could we restore that? So one of the difficulties is it's kind of a two-edged sword, because that phasic dopamine signal is also what's highly reinforcing, right? And one of the limitations as well is, so you have to worry about diversion and abuse liability of these compounds. Even L-DOPA, some portion of Parkinson's patients will abuse their L-DOPA. So we have to think about that. So that's where we think, knowing that these drugs could act acutely, that if you could give them in a controlled setting, such as inpatient treatment, where you don't have to worry about diversion, you don't have to worry as much about the abuse liability, and tie them to the behavioral therapies, then we might circumvent some of those issues. The other issue, which has impacted I think the outcomes of bupropion in the clinical trials, is that if you just give someone the compounds and say, okay, take these this week and we'll see you next week, medication adherence is just poor, whether you're being treated for methamphetamine abuse disorder, or your hypertension, or your type 2 diabetes, what have you. People are just bad at taking their medication. So then medication adherence becomes a negative or a limitation to us being able to show the clinical benefit of a pharmacological manipulation. So I think, again, tying them together in a controlled setting, such as an inpatient therapy session, to restore the phasic dopamine signaling then would be the optimal approach.
I can see where it would be difficult to try and model in mice the behavior of getting a prescription from your doctor, going to pick it up at the pharmacy, bringing it home, and
Absolutely.
taking it. It's a little difficult. So
well, and even, I mean, and this gets back to the selection of the models. I mean, we can say we should be using a rat or a mouse self-administration model, but there's nothing about that self-administration that really mimics the human condition and the human use patterns, if you will, right? So I think we have to be very careful in really thinking about what it is we're trying to model with our animal models, and understanding the limitations of those models, right? While also understanding their benefits.
Yeah, their strengths.
Yes.
Yes. So one more optional follow-up question.
Okay.
What is it that drew you to this line of research initially?
So really, I kind of fell into it when I went to the University of Utah 26 years ago now for my first job, and I've been here ever since. And prior to that, I had done some work with cocaine. I was more in basal ganglia and Parkinson's disease, and a little bit in relation to schizophrenia. So in my graduate work at the University of Pittsburgh, I was in Michael Zygmun's laboratory and worked with Ed Stryker, and they were did some of the seminal work examining the impact of 6-hydroxydopamine and really understanding the impact of large dopamine depleting brain lesions on basal ganglia function. But also kind of stuck in there was the idea and some consideration of the different impact of partial versus full dopamine loss. So I kind of had that background and history in my pocket when I went to the University of Utah, and Jim Gibb, who did really some of the seminal work on identifying that the substituted amphetamines were neurotoxic to dopamine neurons and serotonin neurons, was the chair who hired me. And so when I came to the University of Utah, there was this long history of interest in methamphetamine toxicity. So I came in with my background in studying the impact of dopamine loss on basal ganglia circuitry, and then into this environment where they were interested in how amphetamines caused this partial dopamine loss. So the very first study I did, and I came in 1995, and Laura Nissenbaum, a woman scientist, had published this study in 1995 showing that partial loss seemed to selectively affect certain markers in basal ganglia circuitry, but she used 6-hydroxydopamine. So our very first study that we did in my laboratory was actually to use the methamphetamine toxicity model to see if the partial loss induced by methamphetamine produced these same changes. And that laid the foundation. We did see these changes in some markers of basal ganglia function. And so since then, we've been trying to understand, why is one population of neurons seemingly selectively affected? That led us into the study of the phasic dopamine signaling changes and so on. And so it's kind of progressed since then. And now we're up to the point where we're trying to understand, can we reverse these changes pharmacologically?
That's great. I mean, it's okay to admit that you just wanted to stay in Utah because it's such a beautiful state.
Well, I'll tell you that, I mean, the Chamber of Commerce should pay me because I say, not that we need more people in Utah, but people can come visit, just don't move here. But it's a fabulous place. I mean, I also love the out of doors. If you like the out of doors and having what a big city has to offer, there is no better place. So
so many different kinds of topography in Utah, and all of them pretty stunning. So yeah, I don't blame you one bit. Well, thank you so much for joining us. It was really interesting to hear about your research. We appreciate you taking the time to speak with us.
Well, it's my pleasure. Thank you for having me.